So I'll present the updated results of the first-in-man phase 1 study of ABT-199 on behalf of the 9 academic centres in the US and Australia who participated in this trial, and from the representatives of the AbbVie company who were responsible for the development of the compound. The slides are quite detailed, and they're provided to you in a handout, so I'll speak to the highlights of them through the presentation. So BCL2 has been recognised for more than 2 decades as being critical to the pathogenesis of many hematologic malignancies and is universally overexpressed in patients with chronic lymphocytic leukemia. Preclinical studies from the Dana-Farber Cancer Centre had shown that CLL was dependent for its survival upon BCL2, and studies from John Reed's lab and others had also shown that BCL2 overexpression was one of the main mediators of resistance to many forms of chemotherapy, making BCL2 a very encouraging target that had not able to be selectively inhibited until recently. So ABT-199 is a highly selective, potent, orally administered small molecule BCL2 inhibitor that, in contrast to the earlier compound navitoclax, has more than 100-fold selectivity for BCL2 inhibition over the other BCL2 family member, BCL-XL, that was responsible for dose-limiting thrombocytopenia seen with the earlier compound navitoclax. As we'd previously presented data showing encouraging clinical activity, but which included tumor lysis syndrome, and the revised schedule of stepwise dose escalation with enhanced prophylactic measures was implemented to mitigate that risk. So as mentioned, this was a first-in-man phase 1 study that was conducted in 2 cohorts. I'll be presenting the data from those patients with chronic lymphocytic leukemia or small lymphocytic lymphoma, and Matthew Davids from the Dana-Farber Cancer Centre presented the data on the non-Hodgkin lymphoma subset in a poster yesterday evening. The primary endpoint from the phase 1 study was safety and determination of a recommended phase 2 dose, but of course we also have significant interest in the listed efficacy parameters as part of the secondary objectives. As shown in the top part of the slide, the initial dosing schema had a 50 milligram dose and then a 2-step dose escalation to the designated cohort dose. In fact, in this week last year, there was 1 death attributed to tumor lysis syndrome during the second escalation step from 150 milligrams to 1200 milligrams, which was the highest cohort dose explored. The study was temporarily put on hold and redesigned with a more conservative 3-step dose escalation that the subsequent patients have been treated on with enhanced prophylactic measures, and the initial dose reduced to 20 milligrams with escalation only allowed in the absence of biochemical evidence of tumor lysis. So as of September 30, there are 67 patients currently enrolled with the demographic and disease features as listed here. The highlights I would like to draw your attention to are the median of 4 prior therapies with up to 11 therapies, with 52% of patients having disease refractory to prior fludarabine-containing treatment. The analysis is not yet complete, but of the 52 patients currently analysed, 37% have a deletion of chromosome 17p by FISH studies, and there is not central p53 mutation analysis. So presumably there would be additional patients with mutations in the absence of deletion 17p by FISH. This shows patient disposition. So of the 67 patients entered, 43 remain active and continuing on drug with a median time on study of 10.9 months. Of the 24 discontinuations, 14 have been from progressive disease, 2 for other reasons, 1 patient who required long-term Coumadin treatment for a DVT, and 1 patient who went to allogeneic transplant. 8 patients have come off for adverse events, although 2 of these are related to deterioration of concomitant medical illnesses, 1 due to recognition of esophageal cancer, and no clear pattern for reproducible causes within the others. Serious adverse events attributed to drug are listed here. Of note, although there is a moderate rate of neutropenia, febrile neutropenia is quite infrequent. With the modified dosing schedule, there have been 3 instances of tumour lysis syndrome. Sorry, this is after the initial modification. With the second modification, there have been no subsequent incidents of tumour lysis syndrome, but the 1 sudden death, as listed there, occurred prior to the modification. The infections occurring on study are as listed. In terms of efficacy, and I'll show 3 waterfall plots showing each compartment analysed. The colour coding indicates the designated cohort dose, and although the print is small, above each column, those with deletion 17p or fludarabine refractory disease are designated, and the double arrowhead indicates those with both of those adverse features. So by CT scan, 50 of 57 or 88% of patients had at least a 50% reduction in their lymphadenopathy. The median time to achieve that was 6 weeks, which was the first CT scan stipulated per protocol, and 41 patients had achieved at least a partial remission at that 6-week scan, indicating that cytoreduction is rapid. In other compartments, as shown on the left here, is bone marrow, where the first bone marrow biopsy was at week 24, and 89% of patients have shown at least a 50% reduction in marrow infiltrate, and the median reduction is approximately 95%. In the right-hand panel, peripheral blood lymphocyte count for those with a lymphocyte count above 5 at baseline, showing the median time to a 50% reduction was quite rapid at 15 days. In terms of overall response, in the left-hand column, it's shown for all currently evaluable patients, and to be considered as a responder, a patient required a repeat CT scan confirming nodal reduction approximately 8 weeks after the initial scan. So overall, the response rate is 84%, including a 23% complete remission rate. The middle and right-hand columns indicate those with the adverse prognostic subsets of deletion 17p or fludarabine refractory disease, noting that this is a partially overlapping subset in that 10 patients had both of those adverse characteristics. The overall response rates are very similar at 82% for those with deletion 17p and 89%, so 24 out of 27 for those with fludarabine refractory disease, with complete remissions seen in each of those adverse risk subsets. In addition, although it was not protocol specified, 13 of the patients who have achieved complete remission have undergone testing for minimal residual disease by local laboratory methodologies, and 5 of those 9 have been MRD negative on local testing, including 1 patient with both fludarabine refractory and deletion 17p disease. So in conclusion, ABT199, a highly selective oral BCL2 inhibitor, has clearly shown substantial clinical activity in monotherapy overall and in patients with deletion 17p or fludarabine refractory disease, including complete remissions in each of those adverse risk subsets, and some patients achieving MRD negativity. The risk of tumour lysis syndrome, which occurred with the more aggressive dose escalation, appears to have been mitigated with the more cautious dose titration schedule, and as of this data cut, no additional cases had been seen. So the monotherapy trial is now in safety expansion at a dose of 400 milligrams per day, and ongoing trials, a phase 2 study specifically in patients with deletion 17p is accruing, and combination studies with rituximab and obinutuzumab are underway. Thank you.